waiting room and hands up, Sam? Yes. Yeah, awesome, thank you. Hi, good morning, everybody. So we'll start off with our call to order. Kay's on her way, but
Sure.
we'll start, okay. So we'll do call to order and, so roll call vote, I'll go, alphabetically in order. Dover, if you can say your name and, just say your name.
Jason Belmonte, Dover.
Medfield,
Kathy Thompson, Medfield.
Needham,
Ed Cosgrove, Needham.
and Sherburne.
Daryl Beardsley.
Excellent. So we're officially called to order. And now let's do a quick round. We have a couple new faces one face at the table, sorry, Gail. But with, so traditionally, we go around to introduce the other folks that, are participating that aren't voting. So I'll start. Carrie Janelle, manager for the Shared Services, Charles River Public Health District.
Hi, Gail. Nice to meet you. I'm Sam Menard. I'm the assistant manager for the Charles River Health District. I'm also involved in the training hub as the lead trainer.
Morning, Jen Casey. I am the admin for Charles River Public Health District. Nice to meet you.
She makes all the things happen.
Hi, Gail. I'm Amy McInerney. I'm the regional health inspector. I'm the regional public health nurse, JJ Gatter. Gail Barsa joined just under 2 weeks ago. From 25 years at Patriot South. Welcome.
I'm Tim McDonald, Director of Human Services.
And then the folks that we have on participating remotely, so Amy and Sam, and there are 3 of you, Sam. Perfect timing. Hi, Kathy McDonald. We're just doing introductions of the other folks. If you can just say, yeah, we are kind of what you do. We have, a couple new people.
Sure. My name is Kathy McDonald. I'm the Director of Human Services for Medfield. Nice to meet all of you.
And Corey Martin, who is our environmental health trainer. You just want to say, hey, Pat?
Hello, everyone. Environmental health trainer for the training hub.
Right, so all of our towns will at some point interact with Pat, I'm sure, as we are getting the different trainings out. And we're like, oh, and good. Kay is just coming up the walk, so I see nobody from the public, so we have no public comment. At this time, the minutes were distributed from the January 28th meeting. Okay, welcome. Let's see, there's a spot down there or a spot here. The minutes from the January 28th meeting were distributed. Did everybody have an opportunity to review? And were there any changes? Any changes from Sherburne or Needham, Bethel from Dover, Kathy Thompson, no changes, no comments? Okay. Then I would love to have I would entertain a motion to approve the minutes. So excellent. Is there a second?
Second.
Excellent. So Sherburne, yes, and Sherburne motion, Dover seconded. Now we will roll call vote to approve. Dover.
Yes.
Great. Kay Pearson saying yes. Kay just joined us. Welcome. And then Medfield,
Yes.
Needham,
Yes.
Sherburne. Yes. Excellent. Okay, great. So you can dispense with that. And so then the next thing I put on the agenda, I just wanted to take 5 minutes and ask folks if they had anything they wanted to share, add, ask about regarding the strategic planning. And if anybody if there was a survey, there was a survey sent out that folks were asked to complete, looking at guiding principles, mission statement, and vision, couple different versions. So, folks had an opportunity to see that. And did that process work okay for folks, our first meeting?
Certainly made it easy to have choices and someone else further down.
Yeah.
It worked out very well, I thought. We got a lot done in a reasonably short period of time.
Okay, good. Okay, do you have any? That's fine, no observation. Kathy, were there any observations you had about strategic planning you want to share? I just want to make space for folks.
Yep, nope, it was really great to have the different versions. Took me a little bit to see the differences, but that really appreciated the team giving those to us. That made the process pretty seamless.
Good. So Jen, Casey, and I just met with the team last night. Their kind of final preparations for our next meeting on Thursday, and the agenda for that is posted and will go out to you all after this meeting. We didn't want to confuse anybody by throwing another agenda in the mix. So that will come up, but we'll continue with their work. Okay. Then and if there's not any other thoughts on that, then I wanted to add in something about structure and workflow because we've got, we're starting to build our public health nursing capacity in the towns. And we also have the environmental health work group and just sort of some questions about budget and so on. Can you share those slides that I
How
have?
does,
Say again?
how does slide?
It has the Charles River logo on it.
Yep.
Yeah. Right, I titled it funny. There's,
Let me just go into the presentation. There, right?
oh, I guess. So just a slideshow. Let's go to the beginning. So, from beginning on the left-hand side.
Yep.
There we go. Okay. Next slide. Okay, so I wanted to just take a minute and kind of realign us, remind everybody, and this goes nicely, I think, with our strategic planning work too. For why are we here? What's the work that we're doing? These are the goals from the Office of Local and Regional Health that we operate with, and it's, elevating standards for and improving the performance of local public health. And the other highlighted one would be, advancing sharing of public health programs, services, and functions to achieve effective, efficient, and equitable local public health infrastructure. So those are the guiding things that work for us now in our structure. And as we're working on mission, vision, principles, we will develop our own, but you can see we're already, we're tracking in the same space, right? We've echoed the same kinds of language in our meetings. Next slide. And then this is our old slide. This is something that, I've been sharing since I don't know, whenever my first presentation was as manager for the program, and did this for different individual communities. How does this work? And so our advisory board, each community sends representatives that are sharing insights, expertise, techniques, right? Where our goal is trying to identify common needs and priorities. There are two sources for our work plan decisions, and that's the CART results, and then I guess now we should add the self-assessment results, and the advisory group, and TPH. And then our activities and expenditures, we're guided by, are we advancing the ability to meet the public health performance standards? Are the activities and expenditures of benefit to all communities? Do all communities agree to this? That's one of the key points for us. We operate by consensus that everyone is in agreement. And then last but definitely not least, that we meet our allowable cost guidelines, and we do have to get prior approval for things from TPH. And then the last piece of professional staff are implementing your advisory board decisions, right? We follow your guidance and lead, and I'd say it's a little bit of a dance because I'm putting together agendas and budgets and work plans, working with staff, and hopefully aligned with what I'm hearing from the advisory board, and that we're reflecting your goals. And then we have the that we ask for your feedback and make sure that we're together. And I hope that folks will, you know, I know folks will say, no, that's not quite right, Carrie. And that's how this works. So I think it was just helpful to revisit those. Does anybody have any questions or things we think we ought to add or change on these?
Something just about the allowable cost guidelines, not about changing anything here, but have there been any things that you've encountered so far that you know, thought we would be able to do, but
Yes,
you know, that are like.
the medical
stuff we should-
director.
Oh.
I thought we were gonna be able to do the medical.
Why are you looking at me?
Right, well, because it was the conversation.
I know,
Right, yeah, that's so, I mean, I think that's the notable one. I don't think there were others, you know, I mean, we've talked about conference things and sometimes opportunities come up and there's no out-of-state travel allowed, so, you know, that might, but that didn't really rise to a level. I think the big challenge has been the medical director, which I still haven't solved, but I have not given up.
And
Yeah.
that's the objection part on costs and nope, okay.
That is it's a great question though, because it's not, so the allowable cost piece is more about the allowable than it is about the cost. I would say, you know, it might be 60-40. Is this really does this fit in the guidelines? And then are you spending, you know, is it too much money that you're spending maybe?
We didn't have a flu clinic. How many, buddy?
Oh, boy. So you
So
did? You had a flu clinic?
we did not.
Oh, you did not? Right, because you're not a medical director. Right. So, and I'll add that to the list, but yeah, no, otherwise, and it's a 9-page document that I've, you know, I'm happy to share again, but Jen and I often in our meetings are like, oh, was that an allowable cost? We have the rough ideas, and then we check the document, but it's exhaustive. Yeah, they're very, very clear. Okay. Anything else? Yeah.
Yeah, just the community capacity survey results and how that fits into decision making. Could you give us a concrete example of how you incorporate that survey, the survey results
Yeah.
into decision making?
Maybe he's gonna have a whole presentation today.
Oh, well,
Yeah.
all right, well,
Yeah.
I'm not a plant.
No,
But you don't have to answer it now if you're
Yeah,
gonna
we'll talk
address it.
about
Okay, great.
Yeah.
But just to give you a brief idea, this is the majority of the work we're trying to tackle right now in the EH work group. So all those minimum standards that you filled out, those like exhaustive Excel sheets saying like if you're doing this or you're not, are you aware of this standard? We're going back in right now and tackling all of those and trying to figure out a plan to help all the towns meet all of those minimum standards. So
I see.
Amy's gonna elaborate a lot more later.
Okay.
Thank you. Yeah. Okay, anything else on this one?
Sorry.
No, you're fine. Okay, so I'm guessing no. So this is, this might look vaguely familiar, but I've updated I call it the logic model organizational chart. I've updated it slightly. It looks familiar. I actually. Anyways, so what I added are the pale green things above the workbox, right? So we have our structure, for communities, you know, participants of Board of Health and staff. The advisory board, one vote per community, quorum of 4, all votes unanimous. The staff side, you know, we've always had all the boxes, but it's lovely now, all of the boxes are filled. And then the work is the headline version of the work plan that was given that we signed on with DPH, because no money that we get is free. It comes with, this is what you need to do. And we get to, there's choice in there of, this is an important piece. We choose electives, you know, we choose the elements of it. You'll see in the work, we've got So we pay for the inspection technology for Relevant, the contract with Relevant Technologies. We do the hiring for our own staff, and then we support any hiring for anybody any community, if there's questions about onboarding, if there's a need for interview questions, if there's questions about how a job is structured, all of that is within our realm. We ask folks from the advisory board to participate in our hiring work, to have an opportunity to, sit on the interview panel. And I think that's exhaustive. Health equity, I will say that is the one place that we are, and I own this, we're not making the progress that I'd like to. I've had some trouble connecting with the consultant that DPH has hired to work with all the shared services groups. We talk about it, staff, we talk about it in our meetings and sort of talk about what does this mean? How do we do this? And we've talked about it in reference to creating a new standard application for different things, like what would be some considerations from an equity perspective there. And we do consider it, we're able to benefit from Needham's HR screening structure so that all applications come in through the Needham system, and they are, it's called de-identified. We don't get any names or names of schools or names of employers. We get nothing that would unconsciously or consciously have you say, oh, they went to school with my friend, or, whatever. I know this department, so that we're just looking on the merits of the application. And then if we think that the application shows the skills that we're looking for, skills and abilities and interests, then we ask to unmask it. So that's one of the ways that we do it, and we try and share those tips and practices with the communities. Inspection support, right? Amy and Sam are pretty busy supporting each of the communities. Medfield has been a little bit less, but that has started to shift, and with Medfield's existing agent leaving their position at the end of June, we're anticipating there'll probably be some increased demand there. Grant administration, reporting and governance, I can talk about it a lot, but it's Jen, Casey, and I are work through all of that. We're always attentive to the requirements we have. And you get a monthly report from us, and you get a monthly report of all of the activities that is available for you to share with your communities or to ask questions of us. Then there's the performance standards requirements. Those are written by DPH, but we have some choice in them. And the first one is, are we completing the capacity assessment so that we're able to then kind of see where the needs are. Second one is public health nursing related, and it's developing the infectious disease case investigation standards. And this is all about building the structures that are needed for good delivery of public health services. That's really what our work is. It's not solely providing an inspection. It's about helping create the structure that will support all of the different needs and helping create the decision-making systems for everybody. These are our priorities. And then sustainability, we're supposed to be always kind of thinking about how do we keep this going concern. And what we're doing for sustainability is doing our strategic planning and creating an inventory system of all of the purchases and the things that we keep here as resources for all and the things that we may distribute. I think, so then I just want to underscore, I've heard some different numbers tossed around of what our funding is, and I haven't done a good enough job hitting the number, right? We have $325,000 a year, and that is it. That will be the number for fiscal year 26 and for fiscal year 27. There is no increase in that amount, so we will have to adjust our budget a little bit based on changes in contract costs or changes in salaries as part of the step levels. And then I think I'll highlight too on the staff side, it is noted the percentages that each person is funded by our grant. And I think the notable thing is that no one is 100%. We have, so I am a 50% employee. The other half of my wage, my full-time wage, is I support the training hub. Jen Gingadarin is also a 50% employee, and she's doing the regional public health nursing deliverables. And then her other 50% is becoming a trainer on the training hub side to do work with camps, body art, some housing support. Then we have Amy, who is 75% of her wage. The other 25% also supports the training hub. She is a 75% employee dedicated to, she can do inspections out in different communities, but we also use Amy a lot for presentations, for creating kind of visuals. She's got a knack for that kind of thing, and we're grateful. And then both Sam and Jen Casey are actually funded 20%. So 1/5 of their time is paid for by this grant to support all of the work that we do with the hiring, with the managing of staff, with the figuring out how folks are using their time and what are the priorities. And Jen Casey's work on the reporting, the fiscal reporting, is invaluable because working with the local accounting systems and payroll systems is an art in and of itself for every town, right? And then being able to translate into what DPH needs, we'll work closely. So, and then I added those pale green boxes there in the middle. So overall grant management is kind of how I see what I would call our work, and it's green because it matches the staff, right? Overall, that's what we're doing. We're managing the grant, we're completing the work that's required and recommended. And we do use a couple of subgroups. The environmental health working group is one, and the public health nursing, and it's generous to call you guys a subgroup because it's really Jen, she getting to lead a group, and Gail is representing for Dover and Sherborne. We do have nurses from Needham, and then Medfield is posting for their position, but they'll be working together. So though all of that work in those pale green boxes is at the direction of the advisory board based on the work plan that's identified there. We can modify the work plan, we can talk to DPH about it if we need to make changes. We're taking the lead from the advisory board. So we present information, say, here's what we figured out. This is what we think might be a good approach. What do you think? Do you agree with the priority? Do you not? I thought that those pale green boxes might help a little. The slide that Jen showed, I think if you go to the next one, Jen, is that the one with the scary arrows? No. Okay, I was trying to use arrows to, that was what came up when we first pulled it up. I was trying to use arrows to show the flow, but it just got scary and messy. But that's it. So I guess this was, I'll hop to this, then maybe we can go back to that work thing. But this was the kind of the suggestion list that I started with when we started with the program, and that we continue to use. These were ideas of things that could be done that would be useful for, you know, for health departments. So they're of different sizes, they require staff capacity, they, you know, they would require agreement and support by the board. But that was the, well, we could do this, we could do that. And I think we've stayed pretty close with all that. Now, I mean, we didn't get anywhere with the vaccination clinics. I think that's a structural issue. We didn't have staff. I know it's figuring out infectious disease management and, you know, vaccine dispensing. That's part of the conversation to happen.
So not on that list is the project about fees.
Right.
But that was a special, that's a special project, right? It was using some extra funds to do a project we thought would be helpful, but not something we're gonna continue to to do.
Correct. And this was, yes, thank you for reading that, because, so that project came up as a, well, here's a thought, is this of interest to you all? Would it be useful? Do you think it makes sense to fund it? And we do have the opportunity, we have what we call one-time money, some money available through the CTCI funding that we don't use to pay for staff because it's less real, right? But we can use it for that, and the advisory boards, that was an example of one of the things that, here's something, what do you think? And you all agreed, so yes. And strategic planning actually falls kind of in the same way, we said, do you think that would be worth doing? You agreed, and we're paying for that, we don't have the funds in our budget, we're paying for that with CTCI funds. And that's a appropriate use of it, but,
Well, but I think,
Yeah.
I just think that an additional thing that shared services can do for us is allow us an opportunity to develop ideas like that and discuss possible funding sources, even if the funds aren't part of the grant.
agreed,
Good idea.
agreed, thank you, I'm making note of
And those
that.
are two examples.
And those are two examples here, yep. And they do tie in, strategic planning was one of those things that was an option in the menu from DPH, from our funders, that made it a little easier, right? They didn't have to make a case, but it was by choice. And the fee cost study, we, said, this is what we're talking about, and we're like, okay. So yes, two examples, but right, I like that point, so I can modify this a little bit and we can say it's less that was really written in a hypothetical when it was just Sam and I when we started, and it was, what do we think this will do? So I can shift this maybe a little to reflect our practice as we've evolved, and I'll include that piece of it's a space for, it's a opportunity for collaborative discussion about ideas that would benefit and ways to fund. Okay, great. Anybody else have any comments or thoughts on this?
In a way related to that, that's not necessarily has to be funded through the SAFE program. And it also cropped up in the survey, talking about sharing different expertises that the different member communities have across.
Sharing of expertise. Thanks, Daryl. Can folks on that are participating remotely, are you able to hear us okay? And does anybody have anything to add to or ask with this? Sam's watching the waiting room, the hands up, but sometimes folks don't put their hands up. You can unmute yourself and sing out if you have anything.
Oh, thank you, Carrie. Yes, I am interested in the funding from the grant for public health services as Medfield's reorganizing, as some of you know, the public health department, and they'll be decreasing, at least now before town meeting approves this budget, but decreasing public health nursing hours to a half-time position and adding a public health administrator full-time position in there. So, always interested in what, how shared services could help us with both the reorganization of the department, the questions for interviewing and all that were really helpful, and will be helpful to the team going forward. Currently, what does the shared services grant pay for public health nurses? I know there's some's training hub. Is it just the one? It's really just a half a position for a public health nurse, or is there two positions? I'm always a little fuzzy on that.
So the regional public health nurse is a half-time position. Sorry, the train horn's loud. I don't know if it's.
Yeah.
The regional public health nurse is a half-time position that is intended to support coordination of the public health nursing capacity within all of the communities. And as we were talking in the before we had a person, it was, you know, yes, and they could probably support an occasional blood pressure clinic or, if there was a joint, sorry, I'm looking at you, Gerald, because you said, vaccine clinics, right? You know,
Yeah.
if there was that kind of thing. The work that we have to do with it for DTH is about building those structures, making sure that there's a common procedure that's followed with all the nursing. And then there is funding, and Gail, sorry, this is about, so, there is funding, the advisory board, when it was, creating original budget, I was not part of these conversations, so I retell what I know and y'all can correct me. So the town of Dover successfully approached town meeting and was able to get a position for a public health nurse approved for their town. And that's a 25-hour, the town meeting approved a 25-hour position. And then they went through kind of an odyssey with the personnel board and all of those things, but to actually get the position, and Gail is the result, and we're happy for that. When this when this was being discussed by the advisory board, as I understand it, the thought was, oh, well, do we use shared services funds that would benefit Dover and Sherburne, and as a result, benefit all of the towns, reducing the amount of support that might be needed by Needham. I know Needham was supported, I think Benfield as well, but, and do we make it a full-time position, increasing the attractiveness of the position, increasing the applicant pool, you know, sort of the, providing more options for us. And the advisory board voted yes. So what the advisory board voted for was to fund the additional 15 hours, I think because you're a 40-hour-a-week FTE, right? So to fund the additional 40 hours a week, 15 hours a week to make it a full-time position and support that work. Again, it was a, as I understand it, was a group decision. All agreed that there was benefit to all of the community to support that. So the amount that was allocated was was a sort of a guesstimate based on what might be the wage. And I think we were talking that the cap was $10,000 a quarter to contribute. I don't think that the cost is quite that high in actuality, but we want to make sure that we're dollars available. So long answer, Kathy, but yes, I think, so it's a portion of a nurse that supports 2 of the 4 towns, and that's the dollars that are there. Did that help? And does anybody need to correct me?
And Sherburne does view it as we're sharing those 15 hours with all the communities.
Right, that was also part of the agreement, thank you, Joe, that, you know, the hours that are paid for, by the shared services direct account are hours that if there was a need in another community, we didn't talk about kind of what constitutes need, right? That person will be available as a resource.
I guess my threshold was like major communicable disease outbreak or COVID pandemic, where we need to, you know, do a massive contact tracing function, or we need to do a regional vaccination clinic or something. Not kind of like it's a busy Tuesday in Needham. Right.
That fits with my recollection of our discussion.
Okay.
So I'm sorry, just,
In extraordinary circumstances, not like.
Extraordinary,
Yeah.
not, so kind of in line with the way I've been talking about, but the positions are not the same. But one of the things that I was saying about the regional public health nurse always was trying to make clear that, you know, Jen G's position with us is not a temp, right? That's what my good answer. She's not a temp. She has work to do with helping everybody figure out how to get the proper structures set up and to provide some coordination. So like even the same kind of spirit is what I hear y'all expressing of that 15 hours was not intended that it would be a temp person to run Geneva or Medfield or, okay. Okay,
So just to clarify, the shared services grant doesn't pay for anything for Dover. That was paid for by Dover. And the grant pays for 15 hours for Sherburne. Is that
yeah,
correct?
sort of, sorry, Kay and I are looking, you can't see us, Kathy, but Kate and I were kind of looking and, so sort of, yes. I think that the thing is that it benefits, there's a benefit to Dover, right? Because they were able to secure, arguably, they were able to secure a person of,
Yeah.
you know, more qualifications or, you know, better qualifications, because they were able to attract someone
Yeah.
that was interested in a full-time position.
Yeah.
And again, benefits the whole group because there is then strength in an existing capacity.
And what happened to the money that was allotted for Dover? Or was money not allowed for Dover?
No, there was no allotment for Dover.
Just for Sherburne for the 15 hours?
Yeah, the group agreed, and I'm sorry, I'm speaking for people who were there. Does anybody want to?
You're doing just fine.
Okay.
We're in sync.
Okay,
I
good.
think the thought was that the nursing function was very critical, even though a lot of the shared service was in the environmental health area. We felt that having nursing capacity was kind of essential, and that
Agreed.
Medfield had a full-time nurse, Needham had more than a full-time nurse, Dover had funding that was appropriated by town meeting to get almost full, or, you know, 20 hours a week.
Yeah.
And Sherburne kind of was the missing link.
Yes.
And
The poor stepsister.
right. But that it was important for each community to have some dedicated public health nursing time.
Yep.
Otherwise, you know, everyone was constantly going to be having to pitch in and help, like, on a regular basis every week.
Right.
So by having some dedicated time, nursing time in each community, we can kind of have a minimum level of coverage, and then we can reallocate resources if there's a huge emergency, but
Right.
that was the idea.
And
That's very good, yes.
Sherburne Board of Health spent a couple of years trying to get the idea. Public health nurse in Sherburne Cross. It's been
Didn't work,
successful.
yeah.
Right.
And just a little historical footnote, Dover got this through town meeting just before this group started to form. Had it been timed a little bit later, we never would have had the 25 hours, and we would have been talking here about that 25 hours. But once town meeting had allocated the money, then we had it, and there was no going back. We could, otherwise, to go back, we would have been trying to supplant.
Yeah.
Right.
And that wouldn't have been allowed, so.
And the idea was that Sherburne would be participating in that, and we were unsuccessful. So
That's right, that's right.
24 hours, 25 without hour 15. So-
Yeah.
I will say, and I know communities are different sizes. Part of the way I've been successful in Needham in expanding the staff is getting a grant, having it for 2 or 3 or 4 years, and then saying to the town, oh, the grant might go away. This is such a valuable service, wouldn't it be a shame if we lost it, right? So I don't think that's our concern right now with shared services, but like, I think exposing people to the services you can get.
Right.
You know, I think it's much easier to sell it when they know what they've been getting, right?
Yes.
It's an easier
Yeah.
job to
Yeah.
say we
Yeah.
get public health nursing when
Yeah.
they've actually been getting public health nursing instead of, you know, comparatively minimal coverage by the VNA.
I'll bring you to Sherburne.
I can do that, that's within my scope, and Tim definitely.
What's
And
not
is-
easy to sell, it's definitely not easy to sell.
Yeah. And is
But
that
it's easy.
something that would be looking at again as far as budgeting in towns?
Sorry?
Sorry, and is that sort of the way, is the budget then done each year? As far as, you know, as far as everything but public health services? Is this sort of set in stone for the length of the grant, or Is that something that's looked at each year?
So both, again, right, the dollars, the award that we receive is set in stone. There's some requirements from DPH of what has to be funded. And then, yes, I presented the budget last year, and I'll do the same. And I don't expect that there will be changes. It's not, as I would say, it's not a very, it's not a generous budget. We are not awash with dollars. We are able to do some of the things that we do. But just because we can access that one-time money for special projects.
We have the lowest per capita allocation of any shared service group.
Yes, and that is tied in part to population. Thank you, Ken. It's a function of population. But yes, we have a small amount. So yes, the budget will be presented to you all again. And you know, I think Ed, you observed this last month. Our expenses are largely salary. It's, you know, I think we're 87% is the salaries, the partial salaries of all of the folks that you see listed. So it's me, it's Sam, it's Jen, and it's the part-time hours that we contribute to each of you. So
Not
ahead.
unusual in public health.
Correct. Correct,
And I
yes,
guess, so you as the professional staff or team develop the budget
yes,
based on a combination of this board's priorities
Okay.
and the grant requirements.
correct,
So if, you know, if this group decides we want to hire 100% communication specialists, you got to reel us back and say, well, here's the deliverables we're trying to meet. And I don't know if hiring 6 communication specialists is going to get the job done.
Right.
But ultimately, the board votes.
Yes.
One community, one vote. The board votes on the budget.
yes,
So if the board wants to spend more money on staff training one year and less money the next because they want more technology for inspections or something,
Yeah.
like that's ultimately, the board would give you that direction and you'd adjust the budget.
yes, yes, thank you, yes. Helpful?
It is. I'm sure that, you know, there'll be people in Medfield who ask me, as I'm fighting for our public health nurse position, you know, well, now that you're part of shared services, can't they help? So I just want to have, the correct answers for that.
Yep. And we have, you know, I work with all the times, if there's a town meeting asked, if there's a presentation, if you're trying to put anything together for any of your bodies, I'm happy to talk through the details, help create a slide, use, you know, different talking points. All of these materials, I'll share. I didn't share these slides out because I was working on them last night. I apologize, but I can share them after the fact, and so you can have that schematic, or if it needs to be modified to tell the story differently, I'm happy to do that. Where, as I always say, we really are here to help. You know, there are you know, limitations that we have to work through, but our purpose is to help improve for all of you and for the collective communities, the delivery of the public health services.
Thank you.
You're welcome. Okay, I'm glad okay. Can you go to the next slide? I actually forget what I had. Right, oh, see, there were my scary arrows, right? Aren't you glad I didn't? I was trying to depict that sort of, and I don't know where the advisory board. Okay, no, let's skip over that, because that was one of my thinkings there. I am happy to try to do a different graphic if it helps to show the flow of decision making. If people want to see that, you know, let me know. We can do that another time.
It'd be worth thinking about it. It's gonna be kind of complicated.
Yeah.
It's not an easy, not straight down flow.
Right. It was. Yeah. It's in some ways it's a little circular. Okay. All right. I will keep playing with that, and maybe I'll bring Amy into the field because she has some good eyes. And then I can also, we are able to tap, the epidemiologist that's here on staff in Needham. She provides she's great, Julie McCarthy, regularly. She does great presentations. She's really good at distilling data and thinking things through. So we do tap her for some assistance. Exactly. It's amazing. Okay, I can do that. All right, then I think, we can move forward unless anybody has anything else they want to close on this. We can move forward to staff reporting. So the staff reporting, public health nursing gets to lead off.
Okay, so I do have a few updates from the regional public nurse perspective, and sort of just expanding a little bit on what Carrie and Tim just touched on. Next slide, please, Tim.
Trying to get it into slideshow mode, hang on.
Or you can just hit the thing at the bottom.
There we go. Get it. Okay, so for each town, I thought it would be useful to just go through what I'm doing. So I started covering Maven for Medfield, I think in November. I'm continuing to do that as they do not have a public health nurse yet. That position is posted. So I will continue to cover until that is filled. I've been in touch with Brittany Hardiman, the school nurse lead. We have been keeping kind of a close eye on the flu numbers, which have been high.
Separate slide.
Oh, next one, Jen, sorry. And she is keeping an eye on the school numbers. We also have collaborated with the epidemiologist at the state just to make sure that we are reporting correctly, keeping an eye on any clusters, which we have not yet had. And I created a spreadsheet, which once the public health nurse is hired, I can share with that person. It is a way to track the diseases monthly, and it's useful for the board. Also, at the beginning of this month, I was able to get some COVID test kits over to Medfield. So hopefully those are being used. Next slide, Jen. These are the totals. So if you look at January 2025, we had 62 cases in Medfield of the flu. Compared to January 2024, we only had 12. So you can see that those numbers are very, very high. 57 of those were in the schools. So again, we're sort of making sure we're keeping an eye on classrooms and teams and any place where there may be, a larger number of concentrated cases. So far, that's not been the case. In February, I did these numbers yesterday. There were 28 total. That's still double what last February was. But it does seem that it's on a downward trend. And that is kind of what we're seeing statewide, nationwide. I'm sure some of you saw last month that there were even school closures down in the south, over how many cases have been put.
Jen, are the schools doing rapid testing on site?
No, so they have to go by what the parents are telling them. And then any confirmed test will come to me. I think these numbers are probably larger because
Confirmed tests come to you through Maven.
through Maven,
Yeah.
correct. So any lab test gets directly reported to Maven, then I get that number. Now there are home test kits. I'm sure people are testing at home and those are not part of these numbers. So in actuality, it's probably higher than this. So that's Medfield. And then in Dover and Sherborne, I think Jason mentioned that the VMA last month was their last month of coverage. So on the 28th, I started covering Maven for those towns as well. I was able to provide Daryl and Sherborne an annual report with the disease totals for the calendar year of 2024. I did also go back and include 2023 so that when Gail takes over, we do have those numbers to show trends, and just like I just showed you with the flu, it's kind of important to look back to make sense of the numbers. I was part of, I think somebody already mentioned this, but the orientation checklist and a document for launching public health nurse program. And so lucky to have Gail, who I was able to spend the day with last week, who is getting up and running with Maven. You did your certification, but you're just waiting for access, right? And this sort of aligns with the goals, which I can go back to in a minute, but I provided a packet on disease surveillance. That is one of the deliverables for the grant, which is to create a resource hub. And I also provided her with the template that I just talked about with Medfield. I do not send those with numbers in them, so we will go back together and fill in those numbers. We just have to be careful about what we're sharing electronically. And also on my test kit delivery day, went out to Dover.
Yes, thank you for that.
That's awesome.
And that's, okay, and then I can just, on the next slide, show you some numbers. So Dover also had a big spike in January. I did go over last time how if the numbers are less than 5, this is how we have to report it to protect the identity, potential identity of people being identified. So, similar trend here, and that is another deliverable to monitor for epidemiological trends. And February doesn't seem like it's quite slowing down like Medfield has. So we're keeping an eye on that. And Gail and I were in touch with Amy, the school nurse lead, yesterday. And she is keeping an eye out for clusters as well. So far, nothing. It's sort of spread throughout the schools.
I assume we know nothing about the vaccination status of the cases.
We don't.
Yeah.
I mean,
Do we know anything about flu vaccination rates in the schools?
I don't know specifically in the schools. I think that flu vaccination this year decreased overall. But I don't know that the school tracks that. Sherborne, on the other hand, has gone up this month. For some reason, the spike is a little bit later. So we're continuing to monitor that, and Amy is also aware of these numbers. So we'll see what happens in March.
So out of curiosity, there's that we, Sherborne students go to the regional schools in Dover, but do the numbers still attach to where they live?
Correct, yeah, so
Okay.
so it's their address. So those numbers, yes, so they're Sherborne High School, they're all together, but this is how it breaks down.
So that 19 is mostly students.
So Sherborne did not have a total number. 19 is the total number for the town. And so, yesterday was the first time I spoke to Amy, so she's gonna take a closer look at the numbers, like we did in Medfield to see what the percentage of those are students. My guess is that's a lot of students, but we don't.
I wouldn't expect, considering that students share schools,
Right.
Dover and Sherburne, but they'd be almost identical. I don't know what the size of what's the difference in populations?
It's
Just
just
sure.
2,000,
Yeah.
it's like 1,500, 1,800, it's our last numbers, I think, of different, so Sherburne's slightly smaller, like 1,500 to 1,800 smaller than Dover.
6,200? Yeah.
To 40,
45, yeah.
Yeah, but I will work with Amy to see if we can get a better sense of the schools. And then this is the final slide I had created. One of the deliverables, and I'm sorry, I will go back to the first slide and just go through this one more time, but is to look at the staffing and the resource allocation for public health nursing, specifically for Maven coverage and disease surveillance. And so I also thought about using arrows, but decided not to, because really, as the shared service arrangement, we can all help each other out with coverage. But the requirement is that each town have 2 people trained in Maven. So you'll see in the green, those are filled. So Needham has Ginny, Julie, who's the epidemiologist, could back her up if needed, and so could I. Hannah is also the half-time public health nurse, is also trained in Maven. She could also do that. In Dover, Gail is in Sherborne as well. Gail will be certified to do that. Jason and I had talked about as a second person, he might be willing. We're still having
Put a pin in
conversations.
that.
Yeah, put a pin in that. We're still having conversations about who the second person might be. Medfield, we know, is currently looking for a public health nurse, so we need to have that will be the primary person, and then thinking about a secondary person, and the same as Sherborne, we don't need to think about a second person. And then I have all in the bottom off hours. This is a very rare, like, if a case of anthrax came in on a Sunday or something, who do we call? And so I know in Needham it had previously been Tiffany. And so we need to sort that out with each town. So,
Oh, no, I was just gonna, Jen, I wonder if you could speak to the local Board of Health call put on by DPH a couple weeks ago. There was a special webinar specifically talking, I think it was directed towards like non-medical staff and Maven coverage and sort of their recommendations there and sort of what they were talking about.
Yeah, so I don't know if anybody else was on that call, but it was basically Maven for non-Maven users, I think was the name of the webinar. And they just made it very clear that the person does not need to be a clinician. It can be a health agent, it can be a health director, it can be anybody in the health department, essentially, is kind of the crux of what they said.
Oh, and it's required by the, sorry, Jill, it's like the town has to designate who that person is and let the state know, but they have to grant permission to access the data for the community. And then so they have to be trained, but it's not, somebody can't just send an email and say, hey, I want to do this. Dover would need to affirm that that's who they want.
Can you review the requirements though for the non-clinician, the non-Maven user? So it doesn't have to be a clinician.
Correct.
Any
I think the big takeaway for me was it needs to be someone who's regularly on the platform. You'll get locked out if you don't log in. I think it's
Every
once a
30
month.
days, yeah.
But it was like, if you're only logging in once every 30 days, you're probably not gonna be a very effective user in the event you actually need to do something, to provide coverage on the platform. So a lot to think about in terms of that. Like, it doesn't need to be someone with medical expertise, but does need to be someone who's regularly using the platform.
I was on that webinar. I think the difference is viewing Maven versus clinician who's taking action on something. But when I just recently did the certification, I had a notice that there is no more view access for me.
Right.
So I don't know how they have how you're able to have a second person. If they have to go through the certification.
They have to go through
regardless.
Right, they have to be appointed by the town and go through the certification.
Right, that's right.
And it's
I have to
it's
say,
simple
that's
hours.
not the message that we've got. So, Jean Greco, who is the administrative assistant, has been doing Maven for over 15 years. I'm not sure. And she and the prior administrator would both check Maven daily. Whether they took turns, I'm not sure exactly how they did it, and they would track it over the week as well. So she had an account, and we're not sure why, but the administrator we recently had canceled that and set up as the access point. That person's now gone, and they will not reinstate Jean Greco. Because they're saying she's not a clinician, she's not qualified to do it, and she had been grandmothered in for years of not having that. But the minute it got terminated, they're telling her that there is no way for her to get back in the system.
I think
And
that
she
would
would
also
also
be a miscommunication. They made it very clear on that webinar a couple weeks ago, any of the staff are qualified if the town appoints them to do so.
Oh.
So that must
So
have just
she
been a
needs to find
miscommunication.
someone different to talk to than
Yeah.
whoever
I wonder
has
if
spoken
maybe-
with her thus far.
Mohammed
Yeah.
know the answer.
Yeah.
We can look
Reach
into
out.
that.
Okay, because it's been bothering her.
That's interesting.
It's something she's so used to doing.
She's
Yeah.
providing me some of the numbers from previous years, actually, so.
It's super easy to get locked out of Maven, so I wonder if there's maybe just some type of
She's
error
been
there. that
going
needs to be
around
sorted out.
because once she saw that she had been canceled by the interim administrator for whatever reason. However that happened, we're not sure. She's been trying.
Right, so we
And
can
talk
talk
to
about it. Yeah, we can follow up.
Yeah.
Yeah, especially if she's experienced it.
Yeah.
It seems like it makes sense.
Yeah.
Okay, that's good to know.
So it sounds as if then we all believe, though we're not absolutely certain, that an administrative assistant could become one of our mega users.
I know, we're
Confident they
confident they can.
Okay.
The guidance from DPH the last week or 2 weeks ago was crystal clear that you do not need to be a clinician.
And I think she was checking maybe prior to 2 weeks ago. She's been working on this for a while, so maybe something happened that precipitated that clarification.
Yeah, I'm
We
not
can
sure.
look at, yeah, probably not worth speculating too much.
We'll
but
find out
we'll
some more
find out
details.
what
But it is pretty straightforward, like, you know, if you get foodborne illness, for example, you go into the help section and there's a tip sheet, and you just go through it and ask questions, and it tells you what to advise as far as infection control protocols and all of that. So it is, yeah, we should. Okay. Great, thank you. Yeah. And then I skipped over this slide in the beginning, my apologies. Thank you, Jen, for putting it back. Yeah. So these are the 4 deliverables that I am expected to be working on and has informed all of the work I just told you about. So I need to create a comprehensive resource hub on case investigation procedures, develop standardized protocols for disease investigation. I was lucky Tiffany was able to share what the NEDM policy is, so I've had a look at that, plus what the state has as their protocols, and establish mechanisms, as I mentioned, like with the flu, for evaluating epidemiological trends. And then, as the slide before this just showed, assess staffing. So those are the 4 things that I am tasked with doing as a 50% public health nurse, and that has informed the scope of my work.
And just, so that's not you right? You're not putting on a king hat and deciding. That is in collaboration with the communities, but your job is to be the point on it, to make
Yes.
sure that there is agreement and that everyone's following the same procedure once it's received, that people know how to get the resources and so on.
Exactly, it goes
But
back to what you
you're-
were saying, and just making sure that everybody is standardized. In everything, but disease surveillance being one of those.
How are the standardized protocols different from what are made?
Good question. So for example, the public health nurses here typically, a routine disease, like I acknowledge it that day. I don't like it sitting in my workflow. I think the policy in Needham, it's a couple of days for routine. I think the state allows 7 days for routine investigations. Immediate, we have to do it that day. Yeah. And then there are some that don't need any follow-up, and those you just acknowledge, and flu being one of those.
I know people have asked and no one can ever quite get at this. It's kind of, well, is there an average amount of time that you spend on a case investigation? And there's no such thing, but there are kind of some ranges, right? There's the immediate, there's the routine, which typically you acknowledge and you set, but then there are longer ones, more complex cases. And is there, like, can you speak to what kind of time is spent generally?
Yeah, so you're right, it varies. So one thing that can take some time is if you have somebody who has foodborne illness who is a food handler, meaning they work in a restaurant or a daycare, or they work in a healthcare facility. Many of those diseases require follow-up testing to confirm that the person is negative and is safe to go back to work. So those can be a long time, because you have to wait for people to get better. And then there's a period of time after the antibiotics, so I would say between a couple of weeks and as long as 6 weeks, I had to work on a single case.
Single case, 6 weeks, wow, okay. Any questions on this? This was really helpful, thanks, Jen. Okay, so then I think we've got, Amy and Sam.
You want me to present first?
I think your presentation is gonna cover most of what we want to do, so why don't you go first? See if they
All right, so we're gonna talk a little bit about self-assessments, which I know I've talked to you all many times before. We're gonna talk a little bit about results, and next steps, and we're gonna do kind of a broad overview. If we have more questions, we can get into it. I can also, talk to you all individually about your results too, but we're just gonna do broad overview. Yes.
So sorry, and just to connect some of the terminology here, so the CART that was mentioned earlier, that was the first survey you all filled out, ranging between a year ago and the year before that. This self-assessment is that same survey, just in you are completing it for yourselves format. We didn't submit it to the state. So when we say CART or self-assessment, those are the same questions we're talking about and minimum standards we're talking about.
Thank you, that's helpful, thank you. Okay, so just to remind us all why we're doing this and why we're doing self-assessments and having everyone kind of look at their own standards and where they're at, is we're, as staff, trying to understand strengths and challenges across the collaborative to better give you all the resources that you need to be able to meet every standard, because as a reminder, these are statutory requirements. This is the bare minimum of what the state expects every health department to be doing, based on national law and other different codes and regulations that exist. And by understanding the standards and where everyone's at, we're gonna recommend methods for improvement, based on how everyone identified needing help, whether that was staffing or training or awareness. I'll talk more about that and what exactly that means in a second, but just knowing that information so we can move forward what to do next. So we're gonna go very broad overview of the results, and then what we're doing in turn with those results. So just to start, bring us back to 2022 when everyone originally filled out these questions and then reported to the state. The Charles River Public Health District, as a collaborative, the average score was 85%. So for all the standards, an average of all the towns together, we met 85% of all the standards that exist. And the state average in 2022 was 78. So we were higher than the state average, which is great, but still room for improvement. And then based on self-reporting results to us, not to the state, but to us in 2024, the Charles River Public Health District, again, all 4 towns together, was at 91.5%. So we did go up a little bit, which is great, but we still have room for improvement, which is also great. I did just want to make a note of something that was positive. There's several categories, and I'll talk a little bit more about that. Some of you are familiar with what those categories are because you filled out the self-assessment. But there's no category across all towns where the score is less than 75%. So that's great. That means that no one's like necessarily like really low. Everyone is at least at 75% or higher for every category, at least for the standards that were applicable to your department when you fill this out. So again, very broad overview of results. I split all the standards that were unmet. There was 27 standards that were unmet across all the towns. Split them up by kind of what their general topic was. So 36% of them were related to permitting and regulations. So quite literally, does this permit exist? Should it exist? If you answer no, then you do not meet that standard. Or just different regulations. And the rest, 64%, was just all operations. So things that staff should be doing, the health department should be doing, that currently is listed as an unmet standard. So generally, and actually this will lead to the next slide, the reasons why, there's 4 different categories that if you said that you were not meeting the standard, you'd have to explain why. There was funding, training, awareness, and staffing. As you can see, overwhelmingly, training was the main issue, which is great for us because there's plenty of opportunities out there for improvement. 5 of them, just the staff was just not aware that they had to meet that standard. And then 5 was, we just don't have the staff to meet this standard, which we're gonna look more as we move along into whether or not that's actually a staffing issue or actually a training issue. We're gonna really get into the meat of what exactly that means. And then funding, there was no standard that any town identified funding as an issue. So that's at 0%, so that's why it's not in this pie chart. So this is a lot. So this is a screenshot of a spreadsheet that now exists that has multiple tabs about all standards. So this is a screenshot of the unmet standards. So this is not all of them, this is just some of them. And what we have is we do have, you know, each town, I cut that out just for, you know, that's just for us. But also the number, what the category is, the actual description of that standard, and then the reason why that department was not able to meet it based on their own self-assessment. So some examples of that, you know, for instance, I'm gonna give you an example, some repeat ones, and I highlighted those in pink for myself. Anything highlighted in pink, multiple towns identified that they were not meeting that standard, so it's a repeat, something that we should probably prioritize first. For instance, feeling comfortable going to housing court, a lot of towns said that they didn't feel comfortable doing that, that was this, you know, they want more training on that. Licensing funeral directors, that's a permit regulation, there's a couple of towns that said, oh, I don't do that, I have a funeral home, I should probably be doing that, that is required, so different things like that. And we just are gonna go by category, and then I have status notes, which, you know, where it's at. Some of it we're gonna have to discuss as a group in the environmental health working group, some of it is as simple as sending a form, just keeping a track of where everything's at. But what we're actually gonna focus on first, this is unmet standards, but what we wanna do first is actually look at the not applicable standards. So this is another tab in that giant spreadsheet. And the reason we're gonna do this first is actually a Medfield Board of Health member had great foresight. He had asked, like, anyone that's replying not applicable. So basically you might have a standard where you put not yes or no, but like it doesn't apply to our town. You know, how do we know that that's accurate? There's a lot of them. Most towns put not applicable for a big majority of the questions. And that might actually be true. It might actually not be applicable, but there's a few where looking at them, I think that might be a no. And the reason why is the way that the questions were posed in the self-assessment was, oh, in the last 5 years, did you do this? So for example, in the last 5 years, did you conduct a hearing with your Board of Health for revoked or suspended permits? So you're gonna put not applicable if you didn't do it in the last 5 years, but that can happen at any time and you need to be able to do it. So we're gonna relook at those and see if your department feels comfortable doing that. If not, is it a training issue, staffing, funding, what is it? And we're gonna treat it as an unmet standard from that point on, even though it might not technically be unmet, but that's how we're gonna treat it. We're gonna move it over into that other tab and then address it from there. So I identify these NA standards based on, you know, something that could happen at any time, or it was like a really big repeat, like every town was putting NA. Is that true? And it might actually be true, like for instance, one of them is retail dealers in seafood. I'm gonna assume that actually most towns don't have that actual retail dealer in seafood, but I just wanted to confirm it. And that will probably never come up, but if it does come up, that would kind of be a one-off thing. You don't really have to have your department be super experienced in that. You can use resources available to you. So we're actually gonna look at these all first. I highlighted the ones in green that we're already kind of talking about in the environmental health working group. That's just like my reference. We're gonna work through all these, validate them, and then anything that we really think could be considered an unmet standard will move over, and then we will start addressing those from there.
Quick question.
Yes.
On the questions under standard description, is that what the state has?
Yes, that's the exact verbiage from the self-assessment. I just copied and pasted it. Yeah.
And I'll just say, some of the NAs I think that were identified, and the reason why we want to clean up the data a little bit, some of these are really complex or ambiguous. Even so, you go in, you read the Mass General Law, and you're like, okay, if you have 0 cases of this, for instance, there was the tobacco question about if you had given a tobacco retailer a fine in the past year, and a lot of people answered NA, but I'm presuming that's because they hadn't fined anyone, not that you don't have any retail tobacco permits, and then getting to the crux, well, should that be answered in just because you had nothing to report, or is that a true NA?
Right.
Some of this is, it's a lot, which is why we're trying to spearhead this to help everyone through it, because reading some of these Mass General laws, and the state didn't exactly provide a whole lot of like, here's this question in plain language for us. Yeah. So we're reaching out to SMEs about some of the subject matter experts about some of the questions, and just making sure, hey, if you have 0 things to report, do you still have to report it with 0, or does that not apply to you? So we're gonna get into all of that.
they're gonna essentially create a guidebook for answering these questions.
We're gonna do our best.
I hope so.
Yeah, and
You know,
and
because-
I presume, and you know, these, so I think the next actual cart where we're gonna submit to the state is on track to happen next year. It was supposed to be this year, that timeline got pushed back because GPH decided they wanted to give the shared services collaboratives more time to meet some of these standards. So next year when we do this, we're gonna have our each work group ready to just fly through these questions, right? Cause we'll have a much better handle on them. You'll know exactly what you answered last time. We'll have documented everything we in the EH work group or as, you know, your towns have addressed. And it'll be way less painful moving forwards. And you can confidently say, yes, we were meeting all of the minimum standards. So
Good.
that's the vision and the goal, but we're, in the meantime, these
But you can
spreadsheets
see
are gonna get us there.
Yeah.
Would this be shared across all the different regional districts so that everybody's sort of looking?
Everybody's working on their own version of the results.
Yeah, it'd be nice to have one standardized one for the whole state.
It would be.
It will be.
We'll
I'll make them, the member of the advisory board asked about that. That's good. If I get an ask for it, then, we'll pass it forward and see if they prioritize.
And that's probably 5 years down the road.
Yeah, no, but I think
Wait a minute, your question, maybe I don't understand, this is somewhat customized to our group?
no, there are answers, but the questions are
The
asked
questions
are all
are the same
everyone.
everywhere, but what
Yes.
you're asking is, could we see the data for the whole state or?
Well, in other words, okay, our group interprets this question this way, and this is what our guide says. But out in Berkshire counties, you know, their guidebook said, well, something different, and their answer would be different.
Yeah.
So then you
Yeah,
can
yeah.
compare our
Apples
district
and
with their
oranges.
district. Yeah, it's apples and oranges.
Yeah, right. Yeah, it's just trying to build some
And
internal
the thing is,
consistency.
like,
Exactly.
this is like the very beginning of standardization.
Yeah, right.
So it's probably gonna take a long time to
That's what I'm
get
saying,
everyone
it's
to
at least
engage.
5 years.
Yeah,
down
But it's
the
good to
road.
be talking about it,
Yes,
because, that might go over some people's heads.
That's good, the question comes up.
Yeah.
Yes,
yes.
And I think the way you're approaching it will help us resolve our issues because you're trying to tease out, is it really, in bad shape or not,
Yeah, and I think actually, so
How-
that, the pie chart that was up, and Amy touched on this a bit, where it was mainly training needs. And that's self-reported by staff, and we so appreciate all of the staff and the people who filled this out. It's a lot of work,
Yeah.
and you're all doing your best to interpret these. I think we really wanna tease out too, we were going through, and I think a lot of those training needs are actually gonna shift to an awareness category. And we'll touch base with your staff in the EH work group to make sure everyone's comfortable with that. But a lot of these are just as simple as like, you need a little SOP that says, these are the form you need to send to the state, this is the email you send it to, and the date you need to do it on. That, I don't think we're gonna categorize as a training need more than an awareness and like a little, but that's, so I think a lot of that will shift, but that's what we're starting with cleaning up the data first.
Yes.
And then we're gonna come up with a whole action plan of how we're gonna tackle all of these, so a lot more to come.
Can I ask a bigger question about this at the statewide level? Are there regions, are there shared services groups that are, or are there municipalities that are bucking this kind of standardization, or is it widely accepted that it's important? It seems
it's
to me it
widely-
should.
Yeah, and the groups that have chosen to become part of a shared services group, it is widely accepted. I can't speak for the folks that aren't part of shared services
Yeah.
groups. And we haven't, through the training hub, every training hub is assigned a few of the, I call them unaffiliated. We haven't had a lot of interaction with ours yet, so we can't
You say can't-
characterize it,
Yeah, they're the most interesting in a way. Yeah.
But it's so few towns now that aren't.
Yeah, how many in the state do you think are not?
It's less than 50, definitely.
Right, because it's 3 to 5 assigned to each, and they're 10 hubs, so.
I'm gonna guesstimate 30
But we'll say, so
out of
for
the
example,
351 or two.
right, so one of them is Boston, which is a.
That's a tell me.
They have their own, yeah.
They have their own issues, they have their own, it's a, I used to work with somebody who famously mistakenly worked for Boston and once was presenting something and said, well, the state of Boston says this. And we're like, yes, that was an unintentional, completely accurate thing. Anyways, but they range in size. There's some smaller, there are some larger. And yet there hasn't, so far it seems like everybody is on board within all of the shared services groups.
Awesome. So I showed you this giant spreadsheet, just a small snapshot of it. So you're very lucky, you all get to look at it. So next steps, I will be sending out this spreadsheet to advisory board members and health department staff, just to take a look at it. I don't expect you to do anything with it, but look at it, and if you see anything that pops out to you that you want to prioritize, please tell me, and then we will prioritize that when we're doing this work. But for actual staff and environmental health working group members, right now, we're gonna be working on common NA standards like we just talked about, working through all that, validating that, recategorizing it if necessary. And then once we have all that information, we'll transition into actually working on the unmet standards. And
And at that point, you'll come back, and I think this goes back to that, what the kind of the workflow is. So at that point, once the data's all been validated, everybody's comfortable with it, then you'll come back to present to this group some recommendations, here's how we want to approach this, these are the numbers in each area, these are the steps that will be associated with them, and let this group assess it and decide whether they agree with that or whether they want to prioritize differently or not. And then at that point, once they've done their validation, then it moves back, and that environmental health work group is a vehicle for the digging into it, but it's always at direction of this larger group. So we're working on things that, we might think something's important, but there are other things that the communities might prioritize because we don't know the community as well as you do. So, okay.
And that is it. So thank you for listening. Any questions or thoughts?
Got some
Oh,
slides.
good. Wonderful. Great. All right, so get excited for this spreadsheet. It's very colorful.
I love color coding.
Just
Very funny. The content is good also.
Yes. But yeah, take a look at it. Let me know if there's anything that sticks out to you.
Something we actually had, I asked Amy to crop out the names of the towns up on this presentation. When you get the spreadsheet, it will show you for the unmet standards, which town we're reporting they were unmet. So you can, when you're skimming through, if you just want to focus the ones your towns answered as unmet, maybe that would also save you some time.
Yeah, and this is one of the conversations we have a lot of and sometimes it's important to know what an individual community is doing, and sometimes it's not. And we are needing to have the lens of, so obviously you're gonna focus on Dover, right? Or Sherborne or Medfield. But sometimes it's are we comparing? Are we focusing just on one? Our job is to support the coalition, the four communities. So we're definitely doing, are we at 5,000 feet or are we at 30,000 feet? And we kind of hop back and forth, and that's why it's really important that we get the advisory board feedback, the function of it, never mind just the sort of the legalities and the authority piece. There's a functionality piece, so we're dancing back and forth, whereas you have that special view. So, really nice. Thanks, Amy. Can't see you. Thank you. They've been working we've been working really hard. Okay. So we have about half an hour left, and I have a couple of brief things. I budgeted like 30 minutes for 30 minutes for community discussion, and then I have I think 15-minute CHOPS presentation about the actual foundational public health services assessment process. I know Dover and Sherburne are going to be doing that tomorrow with us. Needham went first last week. Thank you, Jen. And Jen has been working on implementing some of the first steps. So we wanted to take a little time to talk about that. But I don't want to short the community discussion. I had one topic that I wanted to ask you all about. Are there other topics that folks wanted to get this group to discuss or put on our list for thinking about?
The Maven issues.
Yep.
Thing that I had on my list, so that.
Noted, that's good. Let's see what we can do. Joe?
Well, I mean, just to piggyback on the Maven too, we're still trying to get Gail officially into it. But the gentleman from Maven keeps asking for permission from Tim.
Oh, I thought that we had fixed it. Okay,
I
all
thought we
right.
had
I
too.
thought we fixed it. All right, we'll go back and fix it again until it sticks.
I was saying, I don't know if you're hearing, but I was saying that I'll go into the communications for
Yep.
those two towns after this. But I think because it's part of a shared service arrangement, Tim's name is in there. And so that might be why they keep doing that.
And I'm happy to say yes, I just, and we should do whatever it takes to fix this situation, but we should also try to fix they don't need my permission for Dover to
Right.
do Dover things.
Kind of like the
100%.
That's not, that doesn't work right. Yes.
This might be easier to say.
It might be, right,
Let's
fair, fair.
go forward and then we
Do the
fix it.
short term, and I'm sorry, I didn't realize that that it was still that. I thought it was just them leaving them with a backlog on issue. Didn't realize, I didn't get that. Okay, okay, anything else? Kathy, was there anything from Medfield, that you wanted to raise as a discussion issue and in community discussion time?
Nope, I'm all set. Thank you.
Okay, so I had one thing that I was asked to bring to the group, which is that Needham is, I'm gonna pull up my notes. Needham is embarking on a, so Needham is applying for a Metro West Health Foundation grant, focused on health equity and access to resources to support women in birth and people while pregnant and during the first year after giving birth. So this is the description that I was given. With initial implementation in Needham, they hope to provide families with new babies with a variety of printed materials that include postpartum support, breastfeeding and lactation support, helplines and hotlines, mental and behavioral health services, information on infant and pregnancy loss when applicable, and social services. So this is providing materials about all of those topics. And then they would also be providing a gift basket to families with babies that includes diapers, a rectal thermometer, pacifiers, and other small essentials. They'll be assessing interest and evaluating how well the program's going. Long-term goal would be to see if there's interest in expanding the program into all 4 communities. Needham is applying for this on their own. This is one of those, start at one place and see. The idea is that they're thinking of implementing a nurse visiting program that does a baby assessment, visit with the new parents, assessing the home for health and safety, opportunity for answering questions, and possibly providing more resources as needed over the course of the first year after birth. So this is a program that Needham is very interested in. They're preparing their application for it. There are maternal child, there's a maternal child health sort of cohort. There are a few other shared services arrangements in the state that have this as a interest and an activity among them. I know there's a place, I think it's North Shore has a very active program, and they're a resource for getting more information about that. So I was asked to share this information and to get kind of an indication of interest, and would there be willingness to provide, maybe indicate support. I don't know if we do a letter of support, but is there interest in seeing what Needham's work is and possibly looking at applying it in our community? You're not committing to applying it, you're committing to kind of assessing and going. So
First question is it need driven or just
any,
Mother and baby.
it would be any birth in the community, so. Not, I know, no means testing that I'm aware of.
Do we know anything about how programs like this are how useful they are with middle class and upper middle class families?
It's the right question to ask. Obviously, these sort of mental health aspects of postpartum depression and stuff are not something that is confined to any sort of economic
Yes.
category or, but I think that's a fair question, is how many people that do have resources, could easily access resources outside of it, do that? And is the barrier to recognizing that there's a problem? Or is it, I know there's a problem, but I can't find the resources?
Yeah.
I don't know if we have good data on that, but I think that is the question to ask, because obviously our communities do have some number of people that are very limited socioeconomic status, but majority are quite well. Right.
What did you say?
Many of the people in our communities don't need to give back.
Yes, yes.
You know, so maybe you're wasting your resources.
Yeah.
But maybe they need information.
Yes,
About like postpartum.
maybe the postpartum visit from the nurse.
Yeah.
That strikes me just on a gut level as the most useful
I think so.
intervention.
Yeah, I agree with you.
And that could be helpful in assessing the need. If we find there are no data about the need in communities like ours, I'm sure you have a population that's clearly needy.
We do.
But if we can't find data about that and we decide we want to try this, doing something like a nurse visit postpartum would be a way of collecting data as well as.
That's a good point too.
And I'd be, can't speak for all of Sherborne at the moment, but that is my role here. That's fine. I am reluctant to take resources from underserved populations.
Yes.
To apply in our community, but I do agree some of the things like postpartum, if you don't want to talk about that with your friends and family and neighbors and whoever, just having someone who's maybe with your doctor, who knows? That I could see. Now,
So there's a private Facebook group in Dover called the Dover Mothers Association. And it always irked me that it wasn't the Dover Parents Association, but I learned to live with that. And it's a well-established group and they have a leadership structure and there are people, we could probably tap into that and do some interviewing of some influencers to see what they think about this. On the other hand, they may be the most entitled mothers in Dover.
Didn't know that group, not part of that one.
DPA.
What did you say?
He says he's not part of it, so it isn't DPA.
Kathy, do you have any thoughts about about this program in Medfield? Any questions or observations?
Just in my role as a school nurse, even with parents of upper incomes, I really did find a need for, a lot of the teachers would come back with, not even before they came back to school, but just be calling the nurse's office with like breastfeeding questions and lots of new baby things. And often the gifts that I gave them were those basic things, like nobody had a rectal thermometer, until the first time their baby got sick, or, Tylenol, or, so I do still think, I agree that, there's probably other communities that could benefit more. But I do think that would be a need. I think young moms, especially, they've been home from the hospital the same day and they don't have a lot of support. So I actually think that could be a good community resource.
First time parents.
Yep, exactly. Yep.
Yeah. Okay, so I'm hearing interest and great questions about kind of applicability and not no, but kind of the questions of, just wanting to make sure that if there is value, and I love what you said, Kay, about if there's no data out there, if there's no information on utility of this kind of program for that particular demographic, then a chance to gather some and contribute to the literature and the knowledge. So, I will take these questions back to Needham and let them kind of include them in their considerations for the program, and we will ask for an update. You know, this is just, they haven't been awarded it yet, so if they get awarded, we can certainly bring them back in to talk to the group if folks are interested. We could also get information about that program on the North Shore. And we'll keep you aware. Fair? Okay. All right. I am gonna whiz through. I know last month I asked, and you all said, yes, we've heard enough about foundational public health services, but here I am. And I apologize in advance, Ed, because you got to see this already. This is a presentation I've put together for y'all, and then also I will, it's partly in preparation for when we have results from this process. And I am required by the grant to go back out to each of your boards and present on the results of this assessment process. So here we go. Okay, next slide, Jen. So we're doing an assessment, right? We have talked about the foundational public health services forever. And what's happening right now is an assessment is being done for all communities that participate in shared services. It's, you know, kind of a cousin of the CART and the self-assessment piece, but it's looking at more than just the Mass General Law requirements and regulatory requirements. It's looking at this established standard created by FAB, the Public Health Accreditation Board, and what they have established is these 5 areas and then 8 capabilities that are the things that you need to have in place, sort of a minimum standard for effective and good public health in all communities. So these are the content areas. They're very familiar, and they align pretty well with a number of the requirements in the CART. I think notably there's not maternal, child, and family health, and then access to and linkage with clinical care. Those are not current requirements under Mass General Law, but we know they're part of our work, what the work of public health is. Next slide. And then there's the capabilities. And these are the skills and capabilities that are required to deliver on all of those 5 areas. I have a little quibble with the instrument because I'd love to see it if it kind of assessed the capability, like took these capabilities and matched it to each of the 5 content areas. It doesn't actually, but like
You just like arrows.
I do. I like things, yeah, I like things to make sense, but you know, I mean, when we look at these, right, I mean, I think everyone, like, yes, of course, these are the things we need to be able to do in order to effectively do our work. Maybe we don't do as much on emergency preparedness and response when we're talking about environmental health work, but all of these things are part and parcel of how the work gets done. Next slide. So the reason we're doing this assessment is there are 4 key points. The results of the assessment will mean we'll be able to have data-driven decision-making capability, right? So when we're presented, when any board, any group is presented with, oh, should we do this program or not? We're able to look at the data and sort of say, oh, we don't really have this ability, or we do, or hey, it turns out that, you know, maybe one of these communities in this group has great strengths in it. And is this an opportunity for us to learn from each other or to move into an actual sharing of services and say, maybe we want one community to be responsible for this one place. Capacity building, it's a data piece, but it's also, it will be another tool for everyone to provide reasons for why do we need more staff? Do we need to change the way staff are doing work? It'll support that, but then more importantly is it supports all this pipeline work that happens in other places of, you know, recruiting people, trying to help other folks understand what public health is, why they want to be part of it, and hopefully getting folks moving in, getting some education or some certification, and being able to come up and be the next inspectors and the next health directors and the next public health nurses. It increases our accountability. And I like that, but I think increased accountability is because there will be like a common definition that's accessible to anyone. When you say, what is public health? It's these things. We can show anybody in any town, say, here's this, what is public health? It's these 5 areas. We need to be able to do these things. So we'll know, and then it does also increase our accountability, because we will be able to say, oh, are you doing anything about that? How do you address access to care and linkages to care? So that's a great benefit. And then it also is it means that there are resources that we can use to seek other funding opportunities. Just like we were having a conversation just now about maternal child health and that initiative. So, well, what are the data points? And we'll be able to use the results of this assessment to address that. And this is at our level, but then it's also at the state level too, right? Or maybe at the professional association level. The professional associations might apply to conduct some different kinds of training, or, pardon me, the like, based on the results. Next slide. I like this because two reasons. Everything goes back to the blueprint for excellence from the special commission. And it's great bedtime reading, it's great, but it was really important and valuable work. And thank you, Ed, for your service on the special commission and helping us move this forward. But the thing that I really like about this actually is the quote, which is, you need to have clear, comprehensive, uniform, and quantifiable goals, right? What are we working towards? You know, not kind of what comes in at us and what is the current topic that has been raised. Those are important, but it's how do those topics align with the goals that we set for public health, for our community, for our shared services group. Next slide. So the assessment process itself is, there are 2 tools that the process uses. The first one is a cost tool, and it gathers, it's money, right? It's about how much money comes in to the department, and how much money gets spent by the department in delivery of the services. Jen's been working on the Needham spreadsheets for that. It takes into account both operating, and then if there are any grant awards, and then it also for outgoing, it's, do you have a contract with someone to deliver services? You know, are your part-time inspectors, are they by contract, or are they hourly employees and the like? Service delivery, so they're split up, they're separate. Service delivery is just about looking at those 8, those 8 capabilities and the 5 content areas, and there are very specific questions associated with each of those areas that get answered, and that shows a picture then of, well, what are we doing? And, you know, do we do X, do we do Y? There is an ISD tool which include, some communities actually have inspectional services, and that's where the inspection function happens. It's not part of public health departments, so that is there. It is not true for us, so we get to skip that. Next slide. So, as I said, on the cost tool, and that's the piece that we're going to do with Dover and then with Sherburne tomorrow as well. We've already done with Needham. We'll do a dive into the actual tool itself. Encourage folks to pull a couple of reports from payroll and accounting, so that we can talk through how that information might get entered. But this is the details of what it would be. This is all based on FY24 spending, so everybody's contributing the same fiscal year. Jen, I know when you were in pulling it together, your experience was, that a lot of what you need, you can get from accounting and payroll initially, and then.
Yeah, and maybe you might need to reach out to HR for certain questions about whether or not the positions are union position.
Is it union, is it represented, benefited?
Yeah.
What is the actual FTE?
Right, and they wanna know if it's regional or local. And it's pretty basic, so I'm
So,
happy to help anybody that needs it.
so most, it seemed like you said most of the stuff you could get from a
Right, just from looking at
standard
the payroll
report.
system, correct.
But you really need to know your way around it, the payroll and the accounting system for some of it, so that's where it's.
Yeah, for sure, like, some Schedule Cs don't show a budget.
Yeah.
So you have to go in and maybe print a report.
Yeah.
To see what the earnings were for the last fiscal year.
But it wasn't, it's not hard,
No.
right? Right, it's not. And, you know, it certainly is dictated, at least partially by the size of your staff, so, you know, if you have a smaller staff, that certainly means that there's just fewer people to log in. Next slide. So that's the first piece, we're gonna get through that piece, then we're gonna come back to you and we're gonna work on the service tool. This is I love our colorful spreadsheets, and this isn't ours, this was created by the state with FAB. This is what it looks like. There's a headline responsibility, which is another way of describing a question. And you need to answer, you know, who are you? You know, is it the town of Dover? What shared services group are you with? There might be partners that help you, that deliver the service with you, so you get a chance to identify them. You need to quantify that, so it's if I'm sharing this in some way, what percentage of it am I delivering? And then the piece that I'm really interested in is when we look at capacity and expertise, you can see at the top on the right with the blue boxes, there are drop downs. There's no free text, and they're trying to characterize what is both the capacity to deliver this service, and then what's the level of your staff expertise. So capacity might be equipment or space or time, right? That would be capacity, and then expertise we quantify separately. And that I think is lovely because that will vary depending on how the workforce kind of ebbs and flows, right? You might have the benefit of having someone like Jason who's very experienced, and then circumstances might change in 20 years or so. And a new director comes in who maybe wouldn't have the same level of expertise that Jason has. And that has an impact. And I think this ability to track that and sort of call that out is really valuable. So that's the service tool. Like I said, we haven't scheduled those yet. Once we schedule with every town, we will come back and schedule with this. Next slide. And then at the end of the service tool, what we're gonna do is we're gonna go back and the questions about, so on the cost tool, there's a row for each role, not person, but role in the department. And you're asked to assign a percentage of time, percentage of effort, basically, that is spent on each of the foundational areas and the capabilities. And this is where I have my quibble because they're equal. So, you know, I might be spending, Jen might be spending 30% of her time on chronic disease and injury prevention and 20% of it on communications, because that's how it works. So we'll need to go back and do that for every role that was entered on the cost. It's easier to do after we've done all that service piece. So next slide. Couple tips on how to complete it. We want to gather diverse perspectives, so it shouldn't just be Jason answering, you know, Tim took a first pass. And with the cost things, it's definitely more focused. It can be an individual with like a validation reality check. On the service side, very much important that we talk to anybody who's engaged in it. So a conversation maybe with Kay, with the board, you have to figure out how to approach that. you need to use your best judgment, it's not a test, nobody's gonna say, you said you could do this and you can't, but it's, your gauge, right, within the reasons. And then there are technical assistance resources. You'll meet Manise tomorrow. She is our assigned person from BME Strategies, who is available. She'll run through some of this with us. She will be available as a reach back for clarification on the questions, for walking through and entering information into the spreadsheet. All of that, we're well supported with that, and she's great. Next slide. So I just thought I wanted to put this slide in again as a reiteration of why are we doing this. These are the outcomes that we will benefit from by completing this assessment. And I know I just did kind of a whirlwind tour of it, but hopefully I shared some information that validated those things. Next slide. And then so the expectation is that nobody's gonna be doing 100% of any of this. It very well may be below 50%, it might just be 25%. So there's no shame in it. Don't sort of overstate capabilities. It's important to get a good picture of what really is being delivered. And this is an example from Wyoming. So they're at the state level, Wisconsin, sorry, yes. Thank you, Kay. When they had all of their participating communities provide their info, this was the gap that they identified. So the red reflects what was actually being spent, and the gray reflects the additional dollars that would be needed to deliver on all of the foundational public health services, the areas and the capabilities. And obviously, you're not gonna, nobody's gonna find $115.2 million and just say, poof, let's go. So then you start doing a prioritization process, much like we're doing in a smaller level on the capacity assessment, the self-assessment. It will be okay. So where are the priorities and how do we want to go about addressing these? And it becomes another opportunity for, are there things we want to share? Do we want one time to do this? Do we want to find a contract that the shared services group might pay for to have another place take care of a service? So that's that. Next slide. Timeline. Data collection report back should be done by May, I'm told. The results of this will be included as part of the input for our work plan that DPH will be providing information on us on for next year, for FY26. So we'll be able to weigh in and do some of that prioritization using the results from this assessment effort. And then the plan is that there will be a strategy for implementation on the gaps that we'll be working on in FY27. Next slide. Thanks. Anybody get surprised by anything? No? Okay, all right. We'll leave it alone. Done. So then I will just say, this afternoon at 3, there is a webinar, and I know some folks will be able to attend. It's about a data solution. That's what the state's been calling it. It's a data solution that will be available for all, and it I can get a little silly and say, oh my gosh, there's no such thing as one solution to solve all problems. But a lot of effort's been put into it. There'll be opportunity for some input, again, some access to data. And I think as we're thinking about what data do we need, what information can we get from the state, this is where everything apparently is going to be housed. So if anybody has time and wants to join that webinar, we can share the invitation information. I know Amy will be on, Jen will be on, and Jen G will be on as well. And I think I'm gonna be up at a training, but I might step out and get to part of it. And then also there's, I know there was, I know Carol Reed from Medfield had heard about it, particularly she was asking about it. There'll be some more conversation about what the heck is this thing, how does it fit in with our work, and how can we benefit from it? You know, or how might we benefit in the future? So just a plug for that, always good when other folks, hear the information and share their thoughts. And then next meeting, so we're meeting again on Thursday, virtually. We have our strategic plan session 2, and that agenda will come out as soon as we finish up all of this. And then after that, our next meeting will be in March for a monthly meeting. That's scheduled to be virtual. And then we'll have a Thursday, the 27th, will be our strategic planning, also virtual via Zoom. And that's our upcoming schedule. Unless there's any business I didn't anticipate, I would entertain a motion to adjourn. Second, Ed Cosgrove with the so moved. Second, that's good. Second by Sherborne, Daryl Beardsley, thank you. So roll call vote, Dover,
Yes.
Medfield,
Yes.
Needham,
Yes.
Sherburne. Yeah. Excellent, we are adjourned. Thank you all for your time.